Well, I wanted to start off this group with the Waters carbon dioxide absorber. Dr. Ralph Waters invented the first popular carbon dioxide absorber, which made closed-circuit breathing possible. That was such a change in anesthesia practice, where the patient was rebreathing his own air with the addition of oxygen, that it also changed the practice of sedation in many ways. The patient no longer needed such heavy sedation or such heavy doses of inhalation anesthetic, because you just didn't need to use as much to have the same effect. And so many of the sedatives just sort of fell out of favor. And that was just a few years after Labat came to town.
Right.
But it really didn't become super popular until the 30s.
Okay.
And it's, of course, continued in one form or another through today. It's you can't have an anesthesia machine without an absorber.
Right, right. Well, and as an anesthesiologist, I have to say I am very happy that this method of anesthesia is no longer popular. Judith, maybe you want to explain this method of anesthesia?
Also called basal anesthesia. Rectal anesthesia was administered primarily for abdominal surgery or obstetrics. I'm told women didn't care for it much because it involved a tube in a certain orifice. But it was very popular because in the 30s, they still didn't have the types of agents and techniques that we have now, particularly for respiratory support and cardiac support. Heavy doses of anesthetic for long surgeries in particular could have drastic effects on the patient. And so by having to use less of that and being able to concentrate on just a part of the body, that was healthier for the patient. It wasn't enjoyable.
Right, yeah. Another reason why regional became so popular.
Yes, well, it was a form of regional, it just wasn't injection regional.
Right.
Also in the 30s, a new airway came to town, and that was the Goodell Airway. Now, everybody watching this will know a Goodell and recognize that this is pretty much what they use now. When Dr. Goodell invented it, he intended it as an improvement over what was then in use, which was solid metal, like the canal that we saw. In fact, his friend Dr. Waters invented an all-metal airway that he said, that's going to break a lot of people's teeth. And what Goodell came up with was all rubber with a bite block inside made of metal. And that provided the stiffness so that a patient couldn't bite through the tube or occlude the tube with his teeth. And we're still using them. You are. I don't. You use them.
I do.
And you were saying to me earlier that that's pretty much identical to the shape it is now.
It's very similar.
And
very,
again,
very similar.
it's that S curve that's remained the standard, because that's what fits in the mouth.
And then I'm assuming these are the red rubber tubes that were used as an endotracheal tube?
Yes, these are endotracheal tubes designed by Dr. Ivan McGill, a British anesthetist who worked in a hospital that specialized in orofacial surgery. And he needed something that would take the mask off the patient's face, because that's in the way. And he did not like the endotracheal tubes that were available, such as flags, metal tubes. And he said, I got to find something better. He actually worked in his garage to come up with the type of rubber he wanted to use and the shape and the bevel for each tube and the different sizes. And having created these, he then took them to a manufacturer and said, you've got to make these, not just for me, but make them in quantity, because everyone will want to use them. And how right he was.
Yeah.
He's credited with really leading the charge to use endotracheal instead of mask anesthesia.
Yeah. And nowadays, we're very familiar with what we think of when we think of McGill is we think of the McGill forceps, which I'm assuming he created probably at about the same time to help guide this.
Not the endotracheal, the nasal tubes.
Oh, yeah, right. And that's what we still use. Yeah. That's what we still use it.
He invented both at about the same time.
Okay.
Yes.
So yeah, that name is very familiar to us. Yeah, this is very similar to what we use now. Obviously, now we use clear plastic, but very, very similar. Same with the, with this kind of bevel.
The 1930s also brought us barbitol and all the barbiturates, primarily for sedation and not just for surgical sedation. We don't actually have a sample of barbitol in our collection, but we do have barbiturates, including Pentathol. Pentathol is quite famous. It was introduced by Lundy, Dr. John Silas Lundy, who is important in ASRA's history.
And worked at Mayo Clinic.
Of course, another reason to select it. It was a game changer for providing some sedation and some, really, it's more of a hypnotic than a sedative, a different way of doing anesthesia. But it was still pretty, even though it was introduced in the 30s, it was still pretty new in 1941 when Pearl Harbor happened.
Oh, interesting.
And it was used extensively in Pearl Harbor. It was the agent that they had on hand. There was something of an emergency on hand, and there wasn't enough training in how to use it. So there were some anesthetic accidents. Because of the accidents that had occurred by poor training in World War II, Pentathol began to get a bad rap. But it was such a useful agent, and people began to learn better how to use it. It soon became almost a necessary agent. And you were telling me that it was still used when you began your training.
Yeah, so I'm aging myself, but Pentathol was what we had as our IV anesthetic when I started my residency, and I can see why it was probably popular in the war setting, because at least at that time it comes in a powder, and I think you're showing me that this one's even a powder. So I would think that it would be easily transportable, and then I remember in residency, whoever was the first one there that day would have to essentially mix up the big jug of Pentathol, and then everybody would just take their syringes off of that big jug that we would mix up in the day. Clearly, things have changed now with
Pre-dose,
well,
pre-measured.
that and just the control, right? The control of substances such as this. But it was a very different time, even 20-some years ago.
Well, I don't know if this would have made a big jug, but it's definitely multi-dose, because it comes with this warning saying, do not use this on one patient. It's meant for multiple doses.
Well, and I find it funny because, you talk about, and we all know the stories about, all the deaths initially when this first started. But, we have to think about the time that they were in, too. I mean, they didn't have pulse oximeters. I mean, they didn't have, you could take a blood pressure, but it was taken by you with your stethoscope, and so in order to do that while dropping ether, while doing everything else that you had to do, I'm sure they probably didn't check them very frequently. And so one can only imagine why there were so many issues.
It's a job that requires paying attention to 1,000 things at once.
Exactly.
And especially in a stressful situation like you're being bombed.
Right.
That can't have been the first thing on their mind.
Yeah.
I mentioned that for ampules of any kind, they would have used a razor blade to cut through or score it until it could be snapped.
Yeah.
Well, this one came with its own razor blade in the box with the ampule. One of the agents that also came out in the 30s that you specifically told me you wanted to see was tetracaine. And tetracaine had many brand names, including Pantocaine and also Pontocaine.
Yeah. that one I recognize. So
I think tetracaine is still has some use. Is that right, or is it fallen out of use now?
It's pretty hard to find now. But it was still being used when I started my residency. It was the agent that you used if you wanted your spinal to last for a very, very long time. But we have transitioned to other medicines now. But I suspect that you could probably still get it. I just haven't seen it.
A little later, Nuprocaine was introduced, another local anesthetic. It was a fairly powerful one, but not powerful enough to suit everyone. So they came out with another formula somewhat later, intended to be used for long-lasting.
So it says it's Dibucaine.
Yes, that's the original. That's the generic name. And I mentioned that Barbitol was first synthesized in 1930, right on the button. And we have very few in our collection that are that old. But Amitol was one of the first barbiturate anesthetics to come along, and it was used in combination with many other agents.
Yeah. So was that also powder form?
Either powder or crystal.
Okay.
I think most of the Amitol mixes were crystal.
So Judith, why does it say for clinical trial only on that?
This is an introductory product. They went on to make this for the market, but as every new anesthetic or every new drug really it gets developed and tested, there's a clinical period where they're just trying to figure out if it's really safe to use on patients. And that dates from that time period.
So was it limited to who would be able to get it, or was everybody
Yes.
able? Okay.
Yes, probably only someone who was involved in a clinical trial would have had access to this.
Okay.
Next, we're going to come to the Lemon Spinal outfit, which was a very exciting thing at the time. That was introduced in 1940. I think it's fitting that it was introduced in 1940 because that is the last year that ASRA was operating. After that, they did merge with ASA. I wanted to mention also, although it may be obvious from what we've seen on the table as we've progressed, there were very few new agents coming along during the 30s because they seemed to have thought it was all sewn up. Either that or maybe the pharmaceutical companies had better things to do. Sure. But there really isn't much change until Lemon brought out his apparatus.
Which I can't wait to show everybody.
Well, we end our review of agents and objects that were in use during the time that the first ASRA was in business with this Lemon spinal anesthesia outfit, which has several parts. It was introduced by Dr. William Lemon, an anesthesiologist, in 1940, and it was a game changer. This was the first continuous anesthesia administration apparatus.
Yeah, this when I saw this, I was intrigued. So how this works is this is essentially very similar to a needle that we would use today, except this is very large. But it would hook up to this tubing, which then also has a stopcock. And then this is the mattress that went along with this continuous spinal needle and tubing. And it's an incredibly firm mattress, which looks terribly uncomfortable. But I suspect that if it weren't firm, the point of this would not have worked. So I believe what most likely happened is that the patient would sit down or roll over, however you place your spinal needle, and then somehow you had to get them onto this mattress lined up perfectly so that the spinal needle, that their back, where the needle went in, would have been lined up with this hole in the mattress. And knowing that probably about this much or so of the needle would be in the patient, they'd be laying on this mattress, and then the goal would be, I'm assuming they would aspirate, make sure that it remained in place. If it was in place, they would then continue to give local anesthetic to make their spinal last longer. But continuous spinals are a challenge even now with our flexible catheters. I can't even imagine the logistics of having to worry about this contraption and having this hard, stiff steel needle in a patient's back during this procedure. But this, I think that this is really cool and definitely innovative, right? I mean, they saw a reason to need longer lasting spinals, and they came up with a way to do it.
And not only the need to use it for longer procedures, but to do so without having to re-inject.
Exactly.
With all of the dangers of getting the needle placed exactly in the right spot.
Mm-hmm. Well, and especially with the needles that they use, these larger cutting needles, I'm assuming that their post-dural puncture headache rate was pretty high to begin with, and let alone if you had to do it more than once. Yeah. So I don't know when epidurals were created around this time or earlier.
There were epidurals done, but they weren't nearly as widely used as they became.
Sure. Probably because you didn't have a catheter that you could place. So you would end up, I would assume, with the same problem, that you'd have to have that big steel needle in the epidural space.
Well, thank you for coming in today. It's been a great pleasure to have you and to show off some of our treasures today.
Thank you, Judith. And thank you to the Wood Library Museum of Anesthesiology for hosting us. Being able to see these pieces of equipment and these medications in person has been a real highlight and a real joy for me. So I really thank you very much.
You're very welcome. As you know, these are just some chosen samples of the collection that really pertain to ASRA's own history. The collection's been built over many years. We really got our start in the 1930s. And we depend very largely on people donating materials that they no longer need in their practice. but we also sometimes buy, surprisingly. We even find things on eBay.
Oh, that's interesting. Well, yeah, I would recommend a visit to the Wood Library if you're ever in Schaumburg. It's really it's a great place to visit.
Well, we would love to have more people come to see us.
Thanks.
Thank you.